Episode 31, Heel Pain After School Sports. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. Our patient today is a 14-year-old female. She has no significant past medical or family history. She's on no current medications and reports no prior trauma. Her body mass index is 22. She presented with persistent right heel pain for about 10 months. The pain was worse with weight-bearing activities, including her school sports, which included mainly walking and running activities. She described the pain as localized to the heel with occasional radiation to the posterior ankle. This young woman walked approximately 10 kilometers or 6 miles per day to commute to and from school. In addition to walking, she was an active participant in school sports. She denied systemic symptoms. There was no fever, night sweats, and no significant weight loss. On physical examination, she had bilateral pes planus with reduced medial longitudinal arch and mild hindfoot valgus. Tenderness was noted by the authors over the posterior aspect of both heels, particularly at the Achilles tendon insertion. Palpation along the posterior tibial tendon also elicited discomfort. Both active and passive dorsiflexion of both ankles made the pain worse. Okay, differential diagnosis that I came up with. Number 1, retrocalcaneal bursitis. Number 2, calcaneal apophysitis. Number 3, tarsal coalition, ankle sprain, or potential stress injury, and rheumatologic conditions. I want to recognize the authors of this case study. It was published in the journal Cureus in August of 2024 by Yachaoui and colleagues out of Mohammed University in Morocco. I'm Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026. I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, weight-bearing radiographs of both feet were obtained. They showed bilateral flattening of the calcaneal apophysis with mild irregularity and fragmentation. A subsequent ultrasound of both feet revealed fragmentation of the right calcaneus consistent with a diagnosis of apophysitis, according to the authors, but also showed calcification of the distal right Achilles tendon and an effusion in the posterior tibial tendon sheath. There was no identification of retrocalcaneal bursitis and no thickening of the Achilles tendon itself. With the imaging completed, the final diagnosis was determined to be calcaneal apophysitis, also known as Sever's disease, and coincidental posterior tibial tendinopathy. The author's treatment approach was entirely conservative. First, activity modification was recommended. A heel lift was placed inside both shoes, and sports participation was temporarily paused. Topical diclofenac was prescribed for 3 weeks to reduce inflammation and improve pain relief. And finally, physical therapy was initiated. The patient went through 20 sessions of manual stretching along with joint mobilization techniques targeting the gastrocnemius and soleus complex to reduce traction stress on the Achilles tendon insertion at the calcaneal apophysis. After 12 weeks of rehabilitation and conservative management, the patient showed notable improvement. There was reduction in foot pain and enhanced overall functionality. She demonstrated improved mobility and reduced discomfort during weight-bearing activities. Follow-up assessments confirmed successful management without recurrence. Okay, a couple of key takeaways. Calcaneal apophysitis, which may also be called Sever's disease, is the most common cause of heel pain in children and adolescents. It represents a traction apophysitis of the posterior calcaneal growth plate caused by repetitive microtrauma. It accounts for about 16% of musculoskeletal conditions in children in the outpatient setting. This condition typically affects children in the age group of 8 to 15 years with a slight male predominance. Bilateral presentation occurs in approximately 60% of the cases, and it is most common in high-impact sports, including soccer, basketball, and running. This condition often worsens at the beginning of new sports seasons or during a growth spurt. The diagnosis of calcaneal apophysitis is entirely clinical and generally not radiographic. Key examination and findings include a one-legged heel standing test and a calcaneal squeeze test. Both of these physical exam tests demonstrate in the literature high sensitivity and specificity. Pain with active dorsiflexion and tenderness at the Achilles insertion are also common physical exam findings. Important to note regarding radiographic findings, which the authors describe in their article, including sclerosis and fragmentation of the calcaneal apophysis, are common and do not necessarily indicate clinical pathology. One study determined they are found in up to 50% of asymptomatic children with high activity levels. So radiography should be reserved for atypical presentations, severe symptoms, or cases that are refractory to conservative management. The treatment for calcaneal apophysitis, as described by the authors in this case, is entirely conservative. There have been 2 randomized trials that I reviewed. One included a randomized trial of 101 children that found a wait-and-see approach, a heel lift insert, and physical therapy all produced clinically significant pain reduction with no significant difference between modalities at 3 months. A similar randomized control trial over 12 months found no long-term advantage over any single intervention. So this reinforces standard management with activity modifications, anti-inflammatories, heel lifts, and stretching and strengthening of the gastrocsoleus complex as the foundation of treatment. Average time to full recovery is approximately 60 days, with most patients returning to full sport participation within 2 months. Intermittent flare-ups are common until the apophysis fuses, which typically occurs by age 15 to 16. Okay, questions for you. A 12-year-old male soccer player presents with bilateral heel pain that worsens during practice and improves with rest. He is in the middle of a growth spurt. On examination, medial-lateral compression of the calcaneus reproduces his pain bilaterally. There is no swelling, erythema, or bruising. Radiographs show fragmentation and sclerosis of the calcaneal apophysis bilaterally. Which of the following is the most accurate statement regarding the radiographic findings? A. They are pathognomonic for calcaneal apophysitis and confirm the diagnosis. B. They indicate a calcaneal stress injury requiring immobilization. C. They can be present in up to 50% of asymptomatic physically active children and are not diagnostic in isolation. D. They are indicative of osteomyelitis and warrant urgent MRI. E. They suggest avascular necrosis of the calcaneus. The correct answer is C. Radiographic findings, including sclerosis and fragmentation of the calcaneal apophysis, are common and unreliable alone as a diagnostic criteria because they are found in up to 50% of asymptomatic children with high activity levels. Calcaneal apophysitis is a clinical diagnosis based on history and physical exam, not imaging. Question 2. A 10-year-old female gymnast presents with a 6-week history of right heel pain. On examination, there were 2 provocative tests performed. The first involved asking the patient to stand on one leg on the affected side, which reproduces heel pain. The second test involved squeezing the calcaneus, which also reproduced pain. Which of the following best describes the diagnostic performance of these tests for calcaneal apophysitis? A. Both tests have high sensitivity, but for specificity. B. The squeeze test is sensitive, but the one-legged standing test has not been validated. C. Both the one-legged heel standing test and the calcaneal squeeze test have been shown to have very high sensitivity and specificity. D. These tests are useful only in children under age 8. E. The squeeze test is specific for retrocalcaneal bursitis, not calcaneal apophysitis. So the correct answer is C. The one-legged heel standing test has been reported to have very high sensitivity and specificity along with the calcaneal squeeze test for calcaneal apophysitis. These clinical tests are the cornerstone of the diagnosis when identified on physical exam. Question 3. A sports medicine physician is counseling the parents of a 9-year-old boy diagnosed with calcaneal apophysitis. The parents ask about treatment options and which approach is most effective. Based on randomized controlled trial evidence, which of the following statements is most accurate? A. Physical therapy is significantly superior to heel raise insoles and should be the sole treatment. B. Heel raise insoles are significantly superior to all other interventions at all time points. C, wait and see, heel raised insoles, and physical therapy all produce clinically significant pain reduction with no significant difference between modalities at 3 months. D, extracorporeal shockwave therapy is first-line treatment with the strongest evidence. E, anti-inflammatories alone are sufficient and no other interventions are needed. The correct answer is C. According to a randomized trial of 101 children by Wigner et al., which compared wait and see, heel raised insoles, and physical therapy for calcaneal apophysitis, and all 3 groups showed clinically significant pain reduction with no statistically significant difference between the modalities at 3 months. Question 4. Which of the following patients is most likely to present with calcaneal apophysitis? A 6-year-old sedentary female with a BMI of 18. B, a 20-year-old male marathon runner with recent increase in training mileage. C, an 11-year-old male basketball player at the beginning of a new sports season who is experiencing a growth spurt. D, a 16-year-old female with closed growth plates and posterior heel pain. E, a 45-year-old male with plantar medial heel pain, worse with a few steps in the morning. The correct answer is C. Calcaneal apophysitis typically affects children ages 8 to 15 with a slight male predominance and is most common in high-impact sports and typically occurs during the beginning of a new sports season and with growth spurts. The condition does require an open calcaneal apophysis, which typically fuses by age 15 to 16, making it an unlikely diagnosis in athletes older than those age groups. Okay, question 5. A 15-year-old track athlete is diagnosed with calcaneal apophysitis. After 8 weeks of conservative treatment, including activity modification, heel cups, stretching exercises, and anti-inflammatories, she has significant improvement and wants to return to sport. Her parents ask about long-term prognosis. Which of the following is the most accurate regarding counseling with regard to prognosis? A, there is a high likelihood of permanent disability and she should avoid competitive sports. B, the condition typically resolves once the calcaneal apophysis fuses, typically by age 15 to 16, though intermittent flare-ups may occur until that time. C, surgical intervention will eventually be required in most cases. D, the condition invariably progresses to Achilles tendon rupture if sports are continued. E, recurrence is expected in the majority of patients and prolonged immobilization is recommended. The correct answer is B. Calcaneal apophysitis has an excellent long-term prognosis. Average time to full recovery is usually about 2 months, and intermittent flares can be observed until the calcaneal apophysis fuses, which typically occurs by age 15 to 16. And the condition does not typically progress to other significant pathology. Thank you.